On to our final speaker of this segment is Professor Joseph T.K.WU, Sir Robert Kotewall Professor in Public Health, Professor, Division of Epidemiology and Biostatistics, the University of Hong Kong. He will be talking about a showcase of 4 digital health solutions from D2 at InnoHK.
Hello, everyone. Thank you for the opportunity to speak to you today on some of the work that we have done at D2. So as you can see from my title slide, I've slightly changed the title to accommodate the content of this talk. Originally, I was going to go through 4 of the solutions that we developed at the lab, but because of the limited time, I've decided to cut it down to just 3. So D2, if you remember what the Secretary of the Innovation and Technology Bureau, Professor Sundon, said, there were 30 Hong Kong labs in Science Park, and D2 was one of them. And I was the managing director of D2. So this is the JAMA Summit report published just a couple of months ago, basically highlighting what have been the barriers for the adoption of AI technologies in the recent past. So the report highlights that a lot of the evaluation of AI technologies, medical AI technology these days, focused on safety and also technical metrics such as accuracy, F1 score, things like that. However, there have been limited evaluations on the actual real-world effectiveness of these technologies in clinical practice, for example, or in hospital operations. So basically, the report highlights the necessity of formulating a framework, evaluation framework for AI technologies, much similar to what we have been using for drugs and vaccines. And this is also a recent report published, again, just in the past couple of months, resonating what the summit report said. And what this systematic review and narrative synthesis are trying to do is to formulate a new framework, what they call impacts, for evaluating the long-term real-world impacts of AI-powered clinician tools. And the work that we've been doing at D2 have been very much in alignment with these findings of these reports, basically looking at trying to evaluate the real-world effectiveness of AI tools. So what I'm going to talk about in the next 15 or so minutes is to walk through 3 of the solutions that we developed at D2, which I was personally co-leading. So this doesn't represent everything that we did in the lab, just the 3 that I was personally involved in. The first was a LLM-powered HPV vaccine chatbot for improving vaccine uptake in China. As I think most of the audience would know, chatbot has been advocated as a potential solution to a lot of medical informatics problem ever since ChatGPT became a household name about 3 years ago. So this was a RCT done to basically assess whether chatbots of this kind could actually improve public health outcome. Second solution is a digital app that could be installed on a mobile phone without any additional devices. The app allows the mobile phone to be used as a tool for doing heart auscultation. So this was coined phytogram by the inventor of this tool, Professor Joseph from Hong Kong U. The third tool is also an LLM-based solution, basically for doing autonomous cancer staging and risk stratification for viral cancer. So this was motivated by our discussions with our clinical oncologists when we were trying to figure out what kind of AI tools could be developed in order to alleviate some of the current pain points in the Hong Kong hospital system. Okay, so as mentioned, the first solution is a chatbot looking at HPV vaccine uptake. And this was led by Professor Lisa Lin from London School of Hygiene and Tropical Medicine, who was also the Senior Research Director at D2. Some of you might know, Professor Lin is the co-director of the Vaccine Confidence Project, which was founded by Professor Heidi Larsen, who is the world-leading expert on vaccine hesitancy, which has been an increasingly huge public health problem, especially in the past few years, with the uprise of anti-vaxxers and vaccine hesitancy groups in the United States. So the aim of this study is to assess the effectiveness of a chatbot that we specifically developed for HPV vaccines in China for schoolgirls. And the design is a school-based cluster randomized control trial that we conducted in the first half of 2024. This study has been published in Nature Medicine earlier this year. Unlike many other parts of the world, HPV vaccine in China has still been not very widely adopted, mostly because of the fact that the vaccine has not been included in the national immunization program yet. One of the barriers for that was the lack of a domestically available vaccine in the past 10 years. But that has changed. We now have a bivalent HPV vaccine licensed just I think last year or the year before, and the 9-valent version of it is going to become commercially available very soon. So the landscape of vaccine for HPV has been changing rapidly in the past couple of years. And what we're trying to do here is to see whether technology and LLM-based chatbots could help to improve literacy of HPV vaccine among parents and school children, and also uptake, which is the hard public health outcome that we ultimately want to achieve. So the study design is pretty simple. Cluster randomized control trial, randomized at the school level. And we conducted the trial in both urban and rural settings across 2 different provinces. Overall, we recruited more than 2,600 of parents from 180 middle schools. The intervention is pretty simple. In the control arm, we administer what the local health departments would the way that they would promote HPV vaccines, so their standard promotion material. In the intervention group, we let the participants interact with the chatbot that we developed for 2 weeks. The chatbot was specifically developed using GPT-4 as the back engine and making sure that the generative response conform with the material that is compiled by the local health departments. So the way that we do it is using RAG, retrieval augmented generation. The primary outcome is the receipt or scheduled appointments of HPV vaccine for the participants' doctors within 2 weeks of after enrollment. So this is this slide on the results. On the left, far left is the uptick, so the primary outcome that we were tracking. As you can see in the control group, the uptick was about 2% within 2 weeks after enrollment. And in the intervention group, that outcome increased to 7%. So more than 3-fold of increase in the primary outcome. In the middle and the right are the results for the outcome, the secondary outcomes, namely whether the parents seek consultation to ask more questions about HPV vaccines. And on the right is the HPV-related literacy. So basically administer a survey to see whether parents have a better understanding on the scientific facts about HPV vaccine. Similar to the primary outcome, there were statistically significant enhancements in the secondary outcomes. So the results here suggest that the chatbots, in this case, effectively increase vaccine uptake and also improve parental vaccine literacy, especially in rural areas. So chatbots has been advocated as a solution, especially for resource-limited settings, because it's in principle scalable as long as you have the digital technology to support the volume and also as very accessible. So as you know, in China, the digital penetration rate is very, very high. So we implemented this chatbot on WeChat, which is virtually used by almost everybody in mainland China. Phytogram is the second solution that I would like to share with you. As mentioned earlier, this was an app developed by Professor George's whole group in the School of Biomedical Sciences at COCHE. The thesis of the digital solutions that George has been developed is that now that we have a device, namely the mobile phone, which has very, very advanced hardware, there must be some way that we can turn this device into a tool that can help support telemedicine, in particular mobile health, in particular home health monitoring. So that's the thesis of George's work. And this is the first technology that his group developed, which, as mentioned earlier, is an app that would allow subjects to just use the mobile phone, placed it at the appropriate positions of the chest, allow the device to do heart auscultation to detect, for example, any heart murmurs. And we did a validation study at Queen Mary Hospital, which is the teaching hospital of COCHE. So in short, we recruited more than 500 subjects at the hospital. Half of them had valvular heart disease, and half of them do not have the condition. And for each patient, we collect data using Phytogram on 2 different devices, iOS device and also Android device. In addition, we also get the same data using stethoscope, a commercial standard stethoscope, and also using the software coming with the digital stethoscope to detect any valvular heart disease. And finally, the ground truth is obtained using echocardiogram results plus the clinical judgment of our clinical collaborators at Queen Mary Hospital. So long story short, what we found was that the app, Phytogram, the performance is on par with the eStealth. And both of them are quite in alignment with the clinical ground truth. So we were quite excited about these results, and George has founded a startup company, which is based here in Science Park, to further look into the potential opportunities for commercializing this technology. And here are some of the PR stuff that he did. In particular, in the 49th International Exhibition of Invention at Geneva, Phytogram was awarded one of the top awards in the exhibition. The final solution that I would like to share with you is again LLM-powered technologies, which is aimed to do automatic cancer staging and risk stratification for cancer patients. And this was led by Professor Carlos Wong, who is used to be a assistant professor at COCHE, but has recently left and joined London School of Hygiene and Tropical Medicine. So this work has been published in NPJ Digital Medicine, and the idea is very simple. Basically, when we talk to our clinical oncologist friends, when we ask them what are your current pain points that you hope AI technologies can help alleviate, so most of our colleagues are already familiar with the availability and potential application of LLMs. So the first thing that they said was, okay, if LLMs can help us to do some of the information summarization, in particular when we see new patients, that will help a lot, because in Hong Kong, most of the cancer cases are being handled by the Hong Kong Hospital Authority. The Hong Kong Hospital Authority managed more than 90% of inpatient flow. So with that amount of workload, clinicians mostly only have maybe 20 minutes or 25 minutes at most to see a patient. And for new cancer patients, typically they spend more than half of that time basically going through the medical records just to do summarization of the information contained in that stack of papers. So the expectation is that with the capability of LLMs, that amount of work should at least be able to streamline by a substantial amount. So in this study, we try to develop first the algo to do that. For colleagues and peers in Hong Kong, you would know that it's very difficult to work with patient data, actual patient data in the hospital authority, because they are very, very conservative about sharing patient data. So what we did here is basically the first step, the baby step, to try to convince the hospital authority that we can develop such algo, and the accuracy could be sufficiently high to be deployed in a clinical setting. So in this study, we used publicly available data, in particular those from the TCGA project and also from the MIMIC-4 dataset. Understanding data privacy is a primary concern of the hospital authority, and here our goal is to develop a tool that will eventually be adopted by the Hong Kong healthcare system. And therefore, here we focus on using offline LLMs to perform the cancer staging instead of GPT-4, for example, which requires upload of data to the cloud, which we know the hospital authority would say no if it's actual patient data. So we try a collection of different offline models, including Genuine, including Llama from Meta, including Mistral AI, etc. And for each of them, we first work with our clinicians to generate the ground truth, because the data itself, the pathology reports themselves, do not contain the staging. We have to figure out what the staging is by working with our clinicians. And as many of our AI researchers would know, data annotation and ground truth labeling is one of the most time-consuming, labor-intensive, boring steps, uninteresting. And here we are asking our clinicians to work with us to do the ground truth labeling. So you can imagine that this is a very challenging step. So what we did here is to work with our clinician to generate the data annotations guidelines, so that once we have these guidelines as the algo for doing the ground truth labeling, we can delegate the task to our non-clinician members of the research team to do the first pass of the ground truth labeling. And then after they have done that, we then pass on the first set of results to our clinicians to validate whether those preliminary ground truth labeling were correct or not. So long story short, this is the time-limiting step of our project. And then we compare the results generated by the offline models with the ground truth individually, and also in an ensemble way, which means we use some sort of algo to combine the outputs of the different offline models to generate sort of like a consensus output. So what we found when we wrote the paper was that the accuracy could exceed 90%, which sounds pretty good as an academic exercise, but probably not good enough if we want to deploy it as a clinical tool. So since the publication of this paper, we have been trying, improving the algo step by step, and at least for the data that we present here, we can now achieve 100%. Okay. We did extensive entity-level error analysis to try to figure out why the LLMs got things wrong. And this allowed us to refine our results, which allowed us to increase the original 90% accuracy to almost 100% accuracy after we published the data. So now we are working closely with the hospital authority to actually work with the data. So now we are at the stage of accessing patient data from the hospital authority to see first whether the same algo could achieve the same accuracy using actual patient data. And what we find is that the accuracy, as expected, is not as high as what we were able to achieve in the paper. And we are using our insights from the error analysis to now refine the algo. So the last thing I want to mention is that these tools that we are developing are not meant to, of course, replace clinicians. In particular, the area analysis of this work allows us to make a statement on which part of the cancer staging, for example, or risk stratification could be handled very well, or almost certainly by the AI tool, and which are not as well handled by the LLM. So as you can see here, among the 15 or so named entities, only 1 or 2 of them are, the accuracy might be suboptimal, which the implication is that, when we hope that the new workflow would be that the LLMs could handle, let's say, 13 out of the 15 named entities, and the clinicians will only need to focus on the remaining 2 entities, which could substantially reduce the amount of workload at point of care. This is another important component of the work, which is to cross-reference the outputs of the AI with the original inputs in the data, in the pathology reports. So, for example, when you go through the outputs of the AI, the questions they may have is that, okay, which parts of the original report correspond to the inputs by the AI. So we're also currently developing this tool to, again, the end goal is to deploy this tool in the clinical setting, and we recognize that this is a very important component. And we're currently doing an RCT to evaluate the potential impact of this tool in saving clinicians' time for doing the cancer staging. So this is a RCT again. Control group is the normal way that clinicians are doing cancer staging, and the intervention group is to do the cancer staging with the assistance of the tool that we are developing. And the outcome would be, for example, first, of course, the accuracy. Second, how much time clinicians spend in doing the cancer staging with or without the AI tool. So with that, that's all I would like to share with you today. And again, thank you very much for the opportunity to speak with you. Thank you.
Thank you, Professor Wu. Please remain on stage. Now, I'd like to invite Professor Chan back on stage to present a souvenir to you.